What has been the response when you present this solution, you present that data to hospitals, for example? Such an important point that you're making about how disruptive noise can be in that environment. What has been the response to presenting that data to partners that are working with you with these solutions?
Yeah, so there's different ways of there's kind of the process, and then there's the value of the data. And then there's the value of the data throughout that process of presenting it as well. And so the process of presenting the data, we went into this with the hypothesis of just like an active shooter, you would really want that real-time alert if someone's coughing, wheezing, heavy breathing happening, an upper respiratory distress qualified event. If there's something like that happening, or there's a critical alarm that's beeping that nurses aren't responding to because they have such alarm fatigue that it's often just ignored, we assumed, this was again hypothesis going into it, that serving up that real-time notification to the right nurse at the right time would be the best use of that information. And it actually turns out, especially through COVID, as you might imagine, lots of hospitals were overburdened.
Mhm.
Lots of nurses established or really accelerated the burnout stages. And, less nurses serving more patients more frequently in more critical conditions than ever. I would say arguably healthcare, but also specifically hospitals just weren't ready for it. And so they've been more apt to adopt AI and machine learning solutions to enhance that care delivery and the patient experience and just the myriad, because you're never going to have a nurse annotating in every single patient room. These are the critical moments behaviorally and environmentally, specifically acoustically, but imagine visually as well. Lots of different mediums to draw from here. But acoustically, you're never going to have a nurse that's even able to keep up and annotate with every single beep from every hospital pole and all the other sounds. So, we started out with this, let's push a real-time notification, built actually a rule-based system. I could even throw out an example, 5 coughs over the course of 30 seconds with some heavy breathing and wheezing. And you could tag that, time-based over a time horizon beyond a certain decibel threshold and frequency as well, across multiple sound profiles. We could tag that as a rule in our system to qualify that as an upper respiratory distress event by a clinician at that point and have it reviewed. But pushing that out to the nursing station when they're so overburdened, they wouldn't be able to do anything with it. It actually increases that level of alarm fatigue. So what we chose to do is look at this on a high level perspective and say, let's look at the stakeholder that is primarily tasked specifically with quietness in the patient room. Think about sound and acoustics. It's all about quietness. And again, that's a third of our lives if we get 8 hours of sleep. So looking at those critical hours, that rest is so important to recovery in a critical care environment, that right there, quietness specifically, has been the lowest scoring domain across the HCAHPS patient experience survey that's administered by Medicare. It actually qualifies much of a hospital's reimbursements. So putting that together and looking at this from an aggregate view of a patient wing or a floor or an entire facility as a hospital and saying, these are the disruptive spaces in your facility. We can give you access, we can give your nurses, charge nurses access to this data, but they just want to look at this on an aggregate view on a daily, weekly, monthly, and quarterly basis, much like a Google Analytics meets a self-service reporting tool to be able to dial in on their operational excellence and improving operational efficiency to enhance that patient experience while also analyzing the building acoustics. You're never going to have, rugs or carpet on the floor. If you think about all the fluids that exist in a patient's room, the materials that are in hospital rooms refract sound really well. That makes it even more disruptive to the patient experience. So giving them tools to understand the root cause, not just an ambient decibel machine that says it's loud or quiet, and here's a number reading, which is typically what hospitals have done. They'll run a sound study. Those machines are expensive. You get after the fact data, and it's not that qualified. We're actually leading towards the root cause. What was that sound? It was a cough. It was an alarm. It was machinery. It was the door opening and closing and someone slammed it, or there was a squeaky wheel in a hospital cart that needs to be fixed because it's disrupting everyone down the hall. We're actually giving them the root cause for that information, access to it in real time, but more importantly, on an aggregate basis, they're able to have enough information to choose that's actionable to take action on.
That's such a great example of, identifying how much sound tells us about our physical environment, how much sound tells us about human activity or other kinds of activity. That's a great example, and such an interesting way to go about improving operational efficiency, or, as you say, improving the impact, creating positive impact for patients and the patient experience. And as you mentioned, you have a lot of experience through your personal life of that environment. So it's a really great example of using that for positive benefit, using that for benefit.